Hello, good morning. Good morning, everybody, and welcome to this session. This lesson will deal about refractive lens exchange innovations, outcomes, and limitations. We have 4 presentations, but one is missing, and is Aswin Agarwal, who has not announced that he was missing. But anyway, we are going to cover this session with 3 talks about refractive lens exchange, and I would like to introduce my co-chairperson, Dr. Brian Hung Yuan from Taiwan, and I want to thank him for coming here today. Dr. Sri Ganesh should be as well, and he will come later.
Now we begin this section. The first speaker, we invite our good friend and well-known surgeon, especially in refractive surgery and cataract surgery, Dr. George Adio. His speech is its role in modern refractive surgery. Ladies and gentlemen, let's welcome Dr. Adio.
Well, thank you very much, Dr. Brian. And this is my presentation will deal now about refractive surgery of the crystalline lens and cataract and this role today. I have no conflict of interest about this presentation, even though I'm a consultant of some companies dealing with intraocular lenses, but not about the topic, which is purely refractive lens exchange. First, we're dealing about the refractive elements of the eye, and one of the most important, together with the cornea, is obviously the lens, and the lens governs part of the functions of the eye, especially in young persons, by a variability in the focusing capabilities. Because a lens is a complex structure. It has different logics, has different index of refraction depending on the area, and has a role in focusing the light in the retina, and especially during the process in which we can focus according to distance to model and to get a monofocal image in every type of distance, changing the power of the eye according to ciliary body action. Ciliary body action is indeed part of the effect that we have in aging when declining, and indeed this is why a crystalline lens takes a role in the middle age of the middle stage of the life in order to govern the vision and later on to take decisions by the surgeon in terms of how to correct the presbyopia. So the function of accommodation is with the one that has been more intriguing, and the theory that is at this moment much more accepted and partially is the one that has been demonstrated, is the von Helfeld that announced his theory in 1856, in which due to the ciliary body action, active ciliary body action, we have a change in the power of the eye according to distance. This is accommodation, and accommodation depends on factors that are affected by aging. So the accommodation is any other reason by which we can focus not related to the change in the power of the eye, and we have to remember that depth of field and depth of focus are the ones that are today more in fashion in terms of using by different types of premium lenses. Depth of focus is defined as the conjugated plane of the depth of field in the image space, and to certain limits this can compensate in part accommodation. We have to remember that multifocality in the human eye doesn't exist. Multiple focus images are created by the division of the light energy in different focuses when it happens in multifocality. Overlapping of retinal images is not desirable because the dispersion of the light energy has a negative impact in contrastivity, and always this happens to be with a negative perception of the quality of vision. And the normal manipulation of the light in multifocality induces optical abnormalities that are perceived by the patient with different light vision phenomena, which means that the multifocality needs to be adapted to the brain, and the adaptation has to follow any multifocal activity because we have not a multifocal brain. Lens surgery, today we are attending in a paradigm shift. Paradigm shift is happening because the aim of the surgery until recent years was to restore vision in aphakia. And the purpose was the surgical procedure was to get vision, and the residual refractive errors were to a certain extent acceptable as a trade-off for vision restoration. No longer this is true because today improvement in the quality of vision with spectacle independence is the goal. This is why refractive surgery happened to be involved with the lens, and lens refractive surgery is practiced for this purpose, and this is a new paradigm. Development of premium lenses has to be understood in this environment in which we have a change in the paradigm in the performance of cataract surgery, lens surgery, and in general in the perception of the patients why we are as surgeons obliged to do something for them. So we were studying this, and there's a sociological change that was published in Lancet by us. This is a paper that we published about the change in the paradigm that was detected by us, and in this reference is important because it really is an historical change in what we are receiving from the patient as a demand. So we have to define, or to redefine again, which is the purpose of our surgery on the lens. And in order to do that properly, we need to remember what is aging and the decadence of the human crystalline lens, which is indeed what happens to be today the topic of this session. We define, as far as in 2005, in the aging of the crystalline lens, and we published for the first time a paper in which we describe this decadence according with the vision. We choose patients from 8 years to 80 with 20/20 vision, and as a matter of fact, not evident cataract because the vision was good, and we could demonstrate in this paper published in ophthalmology that there was a change along life and with a progressive decadence in the optical properties of the cornea associated to the change that later on was demonstrated in the higher order aberrations. Here you have the course that we published in 2005 about the MTF obtained using the optical quality analysis system in patients from 8 to 80 years of age, and as you see, the MTF changes along life, and this change happens at different layers of the eye. It's not only in the nucleus, and this is getting a moment in it's about from 40 to 45, and precisely about 43, in which the decadence increases logarithmically. This is important because it's a sudden change that happens at the moment in which presbyopia is happening. So all these changes related to age happens the same. The decadence in the MTF, as a consequence, the decadence in transmission of light, less effective transmission of light, higher order aberrations are increased as well, and in general, the function of the crystal lens is in decadence. And this is what we published, and it's happening in different layers of the eye, so it's not only happening at the nuclear level. So this is what is called dysfunctional lens syndrome. Dysfunctional lens syndrome is a triad of aging changes of crystalline lens in which we have presbyopia, higher order aberrations, and lens opacities, and these three stages will be redefined now, and I'm going to show to you how we can identify them. Indeed, we're in the fourth, was the one that was following our studies and our publications, and he published the associated changes in the higher order aberrations later on in current opinion ophthalmology. So the higher order aberrations are happening with time to be increasing, and it happens in all the different higher order aberrations, but especially in the spherical ones. If we want to define the dysfunctional lens syndrome by stage, we have a stage 1 in which the patient lost the ability to adequately accommodate, but still has excellent quality of image and a clear lens. And the best treatment option probably at this moment is perhaps a cornea-based procedure or intraocular lens, because we don't need to replace an element that is functioning not completely well, but is transparent and inefficient. It's a totally different issue. We work in stage 2, in which we have an early pacification that results that the lens has a decreased image quality and higher aberrations. Probably at this moment, the lens-based procedures are the ones that have to be used as far as they can improve these lost functions. And the stage 3 is when we have a negative impact on vision, and this is what we define as a modern wet cataract. Doesn't mean that we have an important loss, but as soon as we have any decay in the visual performance, in the practical terms for the daily life activities of the patient, then we have indeed what is called a cataract. If this is true, obviously we need to demonstrate that the change in higher order aberrations that happen in stage 2 can be improved with intraocular lenses. And in this paper published by Warren in 2018, it was demonstrated with the lenses that were available at that moment that are not the ones that we use today, there was a clear change to better in the performance of the lens, what means that the patient gained in optical performance of the eye with the lens replacement. With this, we have opened the story of the refractive lens exchange. Refractive lens exchange started years ago, and it started as far as 1887. Fukala was the first in Poland that had the first vision about replacing the lens in the high myope, and the Fukala procedure was performed, obviously, in a very early stage with very primitive methods and giving trouble and controversial results. The beginning of the story was this paper was published by Fukala in Poland, and he was the pioneer in lens refractive surgery. He performed the first clear extraction, and by the end of 1889, Remember that the first one was in 1887, but in 1889 he had already treated successfully 16 patients. 16 patients in which he had a decision, he never extracted the lens, and finally with atropine, the patient was 36 months waiting for the absorption of the masses. In the turn of the 19th and 20th century, Fukala pushed all this idea, even that was with a big controversy, and especially academic prominent ophthalmologists like Donders and Bongrave were against this procedure because after almost 3,000 patients operated in Europe along the turn of the century, retinal detachment was described between 3 and 10%. So obviously at that moment we had the consequences of refractive laser change. Remember, Fukala was doing that in the high myop, and this was the first time that ethical performance and convenience were confronted. So Fukala should be acknowledged and refractive laser change as the first refractive surgical procedure as early in 1887. From that moment we had a development of all the different techniques in the cornea, and later on it was in 1989 with Franco Bercel in Italy and Joaquin Barraquer in Spain developed with extracapsular extraction more adequately and using intraocular lenses this technique in the MIP and other refractive errors as well. And it was 1993 with modern phaco modification performed by Lucio Burato in Milano that this became universally accepted, and even that controversial was progressing and indeed is in the stages that we have today with the development of private lenses. So where we are now in 2025. Today, lens surgery is a routine procedure for cataract surgeons. The dysfunctional lenses indeed can be improved with adequate lenses that we can adequate and even customize to the optics of the eye. And we can recover all dysfunction except accommodation, even that some accommodated lenses are now being appearing in the market. The refractive outcome of the lens is very good, and we can calculate it with very high precision as far as we had adequate formulas that does a very good job in standard and non-standardized. And we have new intraocular lenses that can restore the near vision performance using not accommodation but pseudo-accommodation and multifocality with relative success. And we are now in the development and early stages of new accommodative lenses that are appearing in the market. For all these reasons, refractive laser exchange is becoming more and more popular, but we need to acknowledge that there are limits to the performance of this surgery. One of the popularity issues that have pushed refractive laser exchange is indeed the precision, the performance, the skills, and the quality that we have in cataract surgery with modern phaco devices. These devices are available to all surgeons, cataract surgeons, and a cataract surgeon is really with a tremendous instrument in his or her hands in order to improve the quality of the eye by refractive laser exchange in moments in which the decay is evident, or in moments in which the compatibility of this technique with the outcomes that can be used for refractive purposes are adequately accomplished and demonstrated. So refractive lensectomy has pros today as the ability for every good surgeon properly trained, in which the skills of cataract surgery has been properly developed. We have the availability of this procedure for every cataract surgeon with no extra investment. We can accomplish a broad correction of refractive errors with the different type of lenses that we have today. The calculations formulas have been very much optimized. And we have available multifocal presbyopic lenses that even that are multifocal and extended depth of field and accommodative coming soon, they are indeed making a very good job in most of the patients if adequately selected. We have on top availability lenses in unlimited range. These are the pros, but what about the cons? We have to remember that still we have intraoperative complications with postoperative infections that are rare but happens. Loss of accommodation is indeed a major issue. We cannot restore accommodation so far, even that new lenses accommodating are coming with important body of evidence in favor. Posterior capsular ossification still exists, and we induce changes in the vitreous cavity that can lead to retinal detachment and macular disease that have to be taken into consideration in high-risk patients like the MIP. And indeed, we have to balance why we use this technique instead of other surgical available alternatives with the same refractive surgery with good results as well. So the debate today, and is the reason of this session, is how to balance today the convenience and ethics in the indication of refractive lens surgery. We have to understand the outcomes, the limitations, the complications, and to compare them with other alternatives that we have for the correction of refractive errors. The refractive lens surgery today has to consider the indication, the risk exposure, the choice of the most adequate lens, the surgery, the outcomes, and finally, to accomplish accommodation is the final goal and the holy grail that has to be accomplished, and we are at the early stages in which this can be obtained. So conditions for the success are these ones that I'm mentioning to you: balanced indication, which is the reason of this symposium, top quality surgery. The target now is symmetropia and aesthetically independent at all distances, and we need, of course, to get all this, improving the quality of retinal image and not degrading it with lenses that even that provide near vision aesthetic independence is at the cost of quality of retinal image. So we need to know the real performance of different premium lenses in order to make this possible. And finally, I recommend to you to read this paper that we published recently in the European Journal of Ophthalmology about the refractive lens exchange. Where are the red lines? And I hope that we can help to redefine the red lines today with this symposium, in which we are going to put into the scope refractive lens exchange for myopia, hyperopia, in the different ages in order to accomplish the best outcome possible in the benefit of our patients. So take-home messages are really that ethical boundaries are at this moment relatively blurred, and the risk factors and age limits are at this moment necessary to be redefined. Refractive lens outcomes are good and ethical, provided that indications are appropriate. We need hyperopic, myopic, and astigmatic patients to be considered differently because they have different risk factors, and the surgery should be personalized for these patients, and surgery should be granted with state-of-the-art care before and during the surgical procedure, with ethical-based algorithms guiding surgeons to practice this refractive lens exchange on the proper conditions. We have a full chapter about this topic in the new edition, which is the third edition of this book, about multifocal intraocular lenses that are the practice that I co-edited with Joseph Piquel, and will be available in September this year. And in our online course with 500 hours of teaching activities in English, we have extensively treated this important topic with this university certified course that you can follow, as you see here in our university online. And thank you very much for your kind attention.
Thank you very much, Professor Alio. And now it's my pleasure to introduce the next speaker, Dr. Kamal Kapoor, who is going to speak on risk-benefit analysis in refractive lens exchange.
Very good afternoon. Heartfelt gratitude and thank you to Dr. Alio for involving me in this course. Most of the topic has already been covered by him. He's a trailblazer, and in fact, I was just sharing with my friend sitting there, for last 20 years, he looks the same, he acts the same, and he probably has more energy than he had 20 years ago. So I'll be talking about the limitations, the innovations, and outcomes. There will be some crossover between my talk and Professor Alio's talk. I have no financial disclaimer here. So refractive lens exchange is the removal of a clear lens of the eye. Simple procedure. The intention is to correct the refraction. Let's be very clear about that. It did go into a disrepute because suddenly it caught on in Europe, and there was a lot of retina detachments and other associated complications, but then it has come back again. And I will not repeat the same slide. I've had a similar slide by Professor Alio here. It was started in 1776, and then it caught on by Dr. Fukala. But then, in a little short interval of time, a lot of retina detachments, especially myopes, it went into disrepute. What are the optical indications? Of course, emmetropia, especially hypermetropia. We all will understand and agree that hypermetropia is a very, very good indication for a refractive lens exchange, and irrespective of the age of the patient also, as compared to the myopic age group. Anisometropia is probably one of reasons for choice. Presbyopia, especially with the availability of very good quality of diffractive multifocals, trifocals, enhanced monofocals, and even EDOFs. correction of astigmatism. If I get time, I will be showing some patients where I've done refractive lens exchange for patients with 14 diopters of astigmatism, patients with keratoconus, and they've had amazing results. And of course, the concept of dysfunctional lens syndrome. I've been talking about dysfunctional lens syndrome for last 5-6 years, and my partner, Dr. Samir, for those who know him, had 6/6 vision, but he had a DLS. So we ran a DLI score for him on the Tracy. He was having some trouble while playing golf, but he was operating every day. So I went ahead and operated him, and he's super happy. So let us see what are the categories which we would divide the cataract surgery, surgical practice is. Of course, the classical refractive lens exchange, where the lens is removed only to take care of the refraction. And then you have cataract surgery, where the lens has opacified, you remove it. Then you have refractive cataract surgery, where you remove the cataractous lens, also correct the refraction. Then you have the DLS surgery, where the lens probably by standard LOCS scale is clear, but it is causing some aberrations. It is eating into the optical quality. So it is called the DLS, the dysfunctional lens syndrome, and you could do a DLI score on the Tracy and show it to the patient, and these patients do very well. And the last category is the refractive dysfunctional lens surgery, which means the patient has a DLS and he also has a refraction, which is my partner. He had -3.5 with a DLS. So he did fantastically well. So what does DLS actually do? The patient may be actually seeing 20/20 or 6/6, but the optical quality may not be very, very high. The patient may complain of issues. By technical classical methodology, the patient may not be having a cataract, but it's a dysfunctional lens, which means it is not a non-functional lens, it's a dysfunctional lens. So these lenses will cause loss of contrast, and this is how you scale it on the Tracy machine. And if the scale is, in my cutoff, if it's less than 7, I do give the patient an option of going in for a DLS surgery. This is what probably a loss of contrast can look. I'm trying to simulate it for a patient with a DLS, though he's seeing everything very clear, but there is a loss of contrast, the colors are lost, and the brightness is lost. So refractive lens exchange, in my practice, I would usually consider it when the patient is not able to do it for a phakic lens, not fit for LASIK, and is above age of 45. We usually avoid operating younger patients for refractive lens exchange, especially if they are high myopes. But hypermetropes do very well with this. So a younger patient of hypermetropes also, it's a good surgical procedure to be done. The advantage is that the optical quality as compared to a higher refractive correction on the corneal plane, the optical quality with a refractive lens exchange is very, very good. There are no associated dry eyes, no loss of biomechanical strength for the patient, and the greater the correction, better is the quality of vision in these patients. What would be the limitations? Now, some of the risk-benefit analysis, let's see. Whenever you're treating a patient with a high myopia, high axial length, there are very, very strong chamber fluctuations in these patients. And what can happen is these chamber fluctuations itself can cause problems in the vitreous and may cause retina detachment at a later date. There are a lot of studies which do say that the incidence of retina detachment go up to 6% in very high myopes. And also, if you case operating the surgery under block, you can have a perforation. There are reported chances of retina detachment in younger patients, especially when the PVD is not happening. But in hyperopic patients, I have personally experienced, I've operated, I'll be showing some videos, plus 45 diopters of IOL, plus 48 diopters of IOL. Now, of course, I use a piggyback for these patients, not a single lens. But these patients, one of the patients did have an intraoperative very high pressure which needed to be controlled, and it did scare the daylights out of me. So as I said, relax in high myopes can cause RD. Incidence is 1.5 to nearly 6%. There are various literature formulas available there. The concerns, what are our concerns is when you're operating the patient for a refractive lens exchange, the purpose is refractive correction. So you have to be very, very good with your IOL power selection. Luckily for us, there are amazing number of IOL formulas which are available, which we can use, we can tailor to our, standardize our own A constants. We must share with the patient that there will be a loss of accommodation. If in case you go in for the EDOF category of lenses, we definitely give a very good intermediate vision. Using multifocal lenses in high myopic patients, sometimes I burned my hand because of very large pupil sizes. These patients will have photic phenomenon, and these patients may come back to you with more photic phenomenon than your average patient with trifocal or a bifocal. Near glass dependency has to be explained to these patients. What we normally do in patients who are myopic is we do a monovision or a micromonovision after we tested the dominant eye, looking for kappa angle and keratometry, and also looking out for surface disorders, because these patients, if they have surface disorders, they are not going to be very happy because of bad keratometric values which you've taken in, and also post-operative surgery. Now, what are the issues you may have once you have a patient who's got a high myopia and he has a PCO? There are studies which say that when you do a YAG laser for these patients, the incidence of retina detachment is shown to go up. So there are some tricks which are given in the literature which you can use to do during the surgery so that your PCO is less. You make sure that your capsular axis covers the anterior edge of the lens. Cortical cleaving hydrodissection, make sure that the little fibrils and the epithelium on the bag is taken away. Meticulous cortical cleanup, and using special sharp edge lenses which make sure that the migration of the cells do not happen. Another plus point is having very, very high-end machines which give you controlled anterior chamber, so lesser number of fluctuations. Using of bimanual instrumentation, of course, has made the surgery far more safer in our myopic patients also. Now, how to avoid complications by preoperative screening? You do a meticulous preoperative screening. I always ensure when I'm operating a high myope, even if I'm doing a LASIK or a phakic lens, there's scleral depression, a complete screening by the posterior segment surgeon. Young eyes, be very, very careful. As far as possible, avoid doing, at least in my practice, RLE in very young patients. For high myopia, we prefer giving them other options like contact lens in case they cannot be operated by other methods available, lacquer cracks, and any history of retina detachment earlier is a strict no for me. Of course, in hypermetropia, there are a lot of plus points. As it is, these patients have smaller anterior chamber, shallower angles. So doing RLE in these patients will be beneficial for them, and also take care of their thick glasses, which actually give a lot of chromatic aberrations. And the best part is if the axial length is less than 21, this is where you should watch out. I prefer giving these patients perioperative mannitol and Diamox tablet in the morning, and I always give a block to the hypermetropic patients, at least in my practice, in my hands, because I've suffered once or twice. It's a good idea to give the block and give a hypertonic because you do get extra anterior chamber depth in these patients. So what are the innovations? There are various innovations. You have a monovision option. You have a micromonovision, a toric monofocal, toric bifocal, trifocal, enhanced monofocals. Now this is, I think, it's something very unique and very interesting which has happened to our practice, where you're not very sure about the aberrations which the lens may cause problem to the patient. You can go in for an enhanced monofocal with a blended vision of overcorrecting the non-dominant eye by 0.5 diopters. Flax also is giving a huge benefit by giving you a very, very accurate markings and placements of your lens. Piggyback lenses, number of formulas are available. Whatever works for you best in your practice. We are using a lot of Barrett suite in our calculations. Another plus point is the smaller the incision, lesser the fluctuations, safer the surgery, faster the surgery. Newer designs of lenses have been proven to be better. Now, monovision is practically out of practice in my practice, because when you need to give a difference of 1.5 diopters, it's not a very, very good thing to have. I prefer doing the micro mini monovision. What I practically do is I do correct the second myopia on my biometry. Suppose my first correction is 0.12 myopia, I go in for the second one, which is 0.38 or 0.4. So the second eye, or the eye which is non-dominant, goes for the second correction of myopia on the biometer. Make sure your patient is intelligent when you're planning a micromonovision or a monovision. You've explained it to them, do a contact lens trial, or even a spectacle trial on a trial frame to make them understand what it means, because sometimes they will come back and haunt you. They may have said yes in eagerness that, okay, we are okay with micromonovision or monovision, but once you have operated them, they will come and bother you. Ideally, I would take any patient above the age of 45. The power range we will see in the videos which we go forward, dilated retina examination, determination of the dominant eye, bimanual detailed indirect ophthalmoscopy in myopes, very, very accurate biometry, and also record all the astigmatic. So you can actually do a time interval between 5 to 7 days is what I do in my practice. I give 5 to 7 days between one eye and second eye, because it gives me enough time to actually estimate how is the refraction ending up. I always operate the non-dominant eye first if I'm doing an RLE. The reason being, it's a bit more forgiving for me. It helps me to titrate my end result. So I operate the non-dominant eye first, and after 5 to 7 days, I take the second eye first. Pupil size issues, definitely if you have a very large pupil size, you do get caught up. Now this is what I said. Hypermetropia, I prefer giving a block. In myopes, it's a good idea to avoid a block. But one good thing is that myopes, due to the chamber fluctuations, will have a lot of pain. I prefer using Xalocaine intracameral during the surgery, Oculan, or whatever it's called locally. No commercial interest here. Just inject that to make sure that the patient doesn't experience the pressure fluctuations. The patient, especially these high refractive error, do notice increase in their visual acuity, reduction of their aberrations. Now, these are some of the surgical patients I've operated. This is a cylinder of 8 diopters with plus 30, cylinder of -1 with 5 diopters. We will see this, and especially some customized lenses with plus 55 diopters. Now we will see this. This is a patient where we'll just whiz through. These are all clear lens extractions. We do the rexes, small rexes, make sure the lens rexes covers this. So this is 2.5 with the 43 diopters. Very simple. It's not the surgery which is important. I guess it's finding the right formula, making sure your rexes is covered, and we're using an ultra smart lens here. This is a -3 diopter sphere with a 4 diopter cylinder. Again, high myope. There'll be some interesting videos as we go along. Now, these are all simple things. What I'm just wanting to demonstrate is concentrate on your rexes. Make sure there's not fluctuation on the anterior chamber. It's a -3 diopters with a 4 diopter cylinder. Again, a customized lens implanted. Now, this is a refractive lens exchange for a 51-year-old patient. He's a very famous jeweler in Delhi. And I did a C3R for him many years ago. And he had some amount of cataract here also, but it was not interfering. So what I did was I knew that he improves with spectacles till a particular level. So which means the astigmatism was corneal. We ran an eye tracy on him, and we could see that it's most of a corneal astigmatism due to the keratoconus. And see what we got, a customized 14.5 diopters of astigmatism. And it's a customized lens. All you need to do is place the lens bang accurately, and this patient was super happy. 6/12 vision unaided. The best he ever saw with glasses was 6/18, and with contact lens he was seeing 6/9, but he was getting a contact lens intolerance. So we shifted him and gave him this option. We first operated one eye, gave him enough time to wait and settle into it, and then we took care of the second eye. So this is what you can actually do if you isolated that the astigmatism is more due to the cornea. There are sometimes there could be lenticular contributions to the astigmatism, so don't end up correcting that, because then you will be landing in trouble. This is a patient post PK. Again, this is 11 diopters, astigmatism, operated, customized lens, done, dusted, patient doing very well. Very, very interesting cases. Now, this is an IntelliAxis, astigmatic correction, again. This is, again, a clear lens extraction, 34.5 diopters. And there you go. Sorry. Now, we put a trifocal lens in this. This was a lady who wanted this. Again, -6 diopters. So there are plenty of such cases. So refractive lens exchange, I think in the conclusion, is a very, very good procedure. Once you have a very good case selection, you stick to the ethics. You do not operate patients where you should not be operating. A good surgeon should also be able to say no to the patient. That, okay, I would not recommend a surgery because it may cause problems for you later on. So I think refractive lens exchange with all the current armory has a lot of benefits. Once you've mitigated the risk, it's a good surgery to do. Thank you.
Thank you very much, Kamal, and excellent lecture. We have time for discussion afterwards, so I will kindly request you to remain in the room. And it's my pleasure now to introduce you to Dr. Douglas Koch, came from Texas, a long flight. And I thank you because you are going to talk about one of the most controversial issues, which is the performed refractive exchange for presbyopic indication. Thank you, Douglas.
Thank you very much, Jorge. I think you're going to hear a lot of what has been said in these last two excellent talks. But I'm really, Ron asked me to focus on presbyos. And what we should be doing with refractive lens exchange in presbyopes. I don't know how I get rid of that. Let's try again here. Don't know why that came up. All right. Got it. Okay. So I think it really, when you think about refractive lens exchange in presbyopes, I like to group them into three categories. Hyperopes, and you've heard this very well in the prior two talks, hyperopes, myopes, and emmetropes. Hyperopes really are the most ideal patients because they have poor vision at all distances, no risk, very low risk of retinal detachment, and they often have a crowded anterior segment that would benefit by removing the lens. When do you do it? Well, if they have poor uncorrected distance vision, they have clear visual needs or demands, they're contact lens intolerant or firmly reject this option. And, you can do monovision, and I like monovision because these are young people. We don't know what their retina is going to look like in 30 or 40 years. And they may do better with a monofocal lens in monovision than they would with a diffractive lens implant. Trifocals are great. They're getting better, and the quality is getting better. But you have to really be careful. If they're real low hyperopes, say +0.5, they might be unhappy with the glare and the halo from that was different than what they experienced with their uncorrected vision, even if it was 20/25 or 20/30. And my favorite really is the light adjustable lens, because I can put that in and I can dial in what I want for the patient, and the patient can really tell me what to do post-operatively. The accuracy we found with the RX sight is over 90% with a half diopter of target, including post-LASIK eyes. You can dial in the magnitude of the near that they can need and that they tolerate. It has negative spherical aberration, which is a nice benefit in a post-myopic LASIK eye. With post-LASIK eyes, if you're thinking of presbyopes, the IOL calculation accuracy in post-LASIK eyes is only about 75% within a half diopter of target. And so with trifocal lenses, there's going to be concerns if you're going to put that in a post-LASIK eye that wants refractive lens exchange. And it's harder to do adjustment on the cornea in a post-LASIK eye if you miss your target. So these are our results, and I would just call your attention to this portion here. The percentage within a half diopter at Baylor, 96%, post-LASIK eyes, 93%, even RK eyes, 84%, which is far better than what we could have achieved with standard IOL calculations. You also have this interesting thing that when you treat the RX sight lens in a minus direction, going to targeting -5 to -2.5, you double the negative spherical aberration. And what you get from that, we use the VAO Optico to confirm that, is you get a 2.5 diopter range at the 20/30 level. So these patients get a big range of vision with good overlap, and it gets back to Dr. Kapoor's point, which is, you're not making them real minus, they're not making them -150, and yet you still have some good near. The RX Sight LAL Plus is interesting because it has an EDOF characteristic, which is a central steepening that actually extends the near vision as well, and that's something we've had good luck using in these patients as well. Okay, so now we've talked about hyperopes. Let's turn to presbyopic emmetropes. Well, you have to be careful on these patients, to my view, because if you're going to operate on a presbyope who is emmetropic and you don't nail the distance vision, you've got a patient who's really unhappy. So I go very cautiously in these patients. And my thought is maybe just do one eye for near. Do a contact lens trial, and you can use a monofocal IOL, you can use the RX sight, and frankly, you could do a hyperopic LASIK on this patient, which would be just fine. You're not aiming for that much minus, you're not going to distort the cornea that much, but you have to weigh all the various options for these patients, I think, before you jump in and do refractive lens exchange. And sure, the lens may be dysfunctional at age 45 or 48, but if they're 20/20 uncorrected at distance, I'm a go slow approach with these. Now, finally, if we turn to myopes, and this has been addressed, the issues are several, of course. If it's a low myope, these patients have great uncorrected vision, and you have to, with both eyes, and they're used to having this fantastic reading vision, computer vision. Taking that away, you're not really maybe benefiting that patient, and of course the risk of retinal detachment. And so I called on my good friend Oliver Findle in the MyoPred study. See, I'm one American who actually likes my European colleagues, unlike my president. So this study is really a fantastic study done by ESCRS. And it looks at the influence of posterior vitreous detachment on retinal detachment after a lens surgery in myopic eyes. And these are 3-year results. And the inclusion criteria, 21 years or older, axial length of 25 or higher, no other comorbidities. Getting back again to Dr. Kapoor's point about if they have some other retinal pathology, you really want to be careful. So here's the baseline vitreous status. It's interesting that that they had a study group and they had a fellow eye group, that about half of the patients had a complete posterior vitreous detachment, 25% had incomplete, and 9% had no posterior vitreous detachment. 11% of them they really couldn't tell from the OCT readings. So the time to complete the posterior vitreous detachment, if they didn't have one at 12 months, 25% of the patients went on to have a posterior vitreous detachment following lens surgery. If they had an incomplete posterior vitreous detachment at 12 months, 43% of the patients had went on to get a complete posterior vitreous detachment. That tells you what you're doing to the vitreous if you're removing the lens. And look at the incidence of retinal detachment. If they started with a complete posterior vitreous detachment at 3 years, 0.4%. If they had no or an incomplete posterior vitreous detachment, there's a 3.4% incidence of retinal detachment. So that's, that's 1 in 30 that are getting a retinal detachment. It's not a small number. So the conclusion from their study is that eyes with no or incomplete PVD before surgery had significantly higher RD risk than eyes with complete posterior vitreous detachment. Again, 3.4% versus 0.4%. So the preoperative status of the vitreous is a useful parameter for RD risk. And they also, I didn't have time to go through all this, but the high risk group are young males. We know that from all other kinds of studies. Men under age 50 or even under age 60 are at much greater risk than others. So they're going to be presenting the 5-year data, which I'm really looking forward to hearing at the ESCRS Congress in Copenhagen. So myopic presbyopes. So again, low myopia, do nothing to, do nothing to cause them to lose good near vision. So that I worded that incorrectly. And if they really do want some monovision, they have a clear lens, you want to avoid the surgery, LASIK's not a bad idea. You could do monovision with that. The other thing to think about is a myopic presbyope, maybe do a phakic IOL in these patients. Admittedly, the target audience for phakic IOLs is younger, but a phakic IOL can be a placeholder if there's enough space in the anterior segment and the risk of retinal detachment is less, and then we can let the vitreous cavity, the vitreous status evolve naturally rather than precipitating an acute posterior vitreous detachment. And we have new presbyopia correcting models, the STAR EVO. We have lenses that are available in Italy, the CARE Group IPCL, the Optec Artiplus, which is coming along. So, and there's really a low risk of cataract with a STAR EVO lens. And guess what? If a cataract occurs, you just do lens exchange, which you've been able at least to delay it. Now, if they have an early cataract, well then, sure, you could do refractive lens exchange. Again, especially if there's a PVD present and there's no retinal pathology. So, final thoughts. Cornea curvature changes with age. It goes to an against the rule shift to 3/8 diopter per decade. So you want to account for that in your astigmatism planning. Leave the patient with a little bit of with the rule astigmatism. Spherical changes can occur in pseudophakic patients also. So you have to advise these patients of the possible need for corneal refractive surgery in the future if they want to retain excellent uncorrected acuity. And so we're still waiting for accommodating IOLs, and the wait continues. Thank you.
Thank you very much, Douglas Andy. And indeed, we have a very, very interesting topic to talk about. And we were missing two presentations. One was hyperopia, another myopia, but I'm sure that we shall be able to complete this session with that adequate debate. And the debate is about refractive lens exchange. And the first is about dysfunctional lens syndrome. So when should we remove a lens? When is going to be better to remove the lens than to make any other change in the eye? And that is depending on the counterbalance with the risk. And my first question, and this is just for you, Douglas, you were the last, and the first question for you, is when do you consider, because you talk about the myopia study, the refractive lens exchange is ethical to be performed for refractive purposes, because we have three groups: the low myopes, you already pointed out, the intermediate myopes, and the high myopes, and we have to match with age, because age makes a point in PVD, and PVD is difficult to diagnose in the high myope. So this is one question.
Yeah, it's a really great question, a very thoughtful question. You know, I'm very cautious in myopes, and what pushes me over the edge is if they are unhappy with the quality of vision, even with their correction. And that to me is a sign that the dysfunctional lens is really kicking in. I just operated on a PhD in mathematics at University of Houston. She was admittedly a low hyperope. She was only +1/2 in both eyes, 20/25 plus uncorrected. Very unhappy with quality of vision and difficulty seeing and feeling that she couldn't drive at night. I did the RX sight on her, and now she's plano and -1.25 in the other eye and spectacle independent and very happy. So that's a hyperope. But in the myopic group, again, you know, if they're really unhappy with quality of vision, you know, you can go ahead and do it, but you have to be very cautious.
Yeah, I think that definitely in the map, if you cannot provide very good vision for near, you have a problem, you know, because the patients are good for near. Definitely, it's the only one of them to be a myope, and they will not decline the near vision quality at the cost of getting far vision. This is one point, and there's the counterpart. What do you think now? Because we have the privilege to have very distinguished colleagues, and I think that you may have a point here as well.
Myopes, I'm very cautious about doing clear lens extraction because they have bigger eyeballs and the kind of volumetric changes that happen, and already they have some amount of vitreous pathology because of the myopia. And what I find in my practice is if there is a natural PVD that occurs, the risk of RD is actually lesser than when you do a refractive lens exchange, because suddenly you have a volumetric change, the vitreous has not degenerated adequately, you have a lot of traction because of the volumetric change, and then you have a PVD, the risk of retinal detachment is more because you have more traction. If it happens naturally over a period of time, then there is first vitreous degeneration, the attachments of the vitreous and the vitreous base actually reduces, and then you have the PVD which reduces the risk of retinal detachment. So I'm very cautious about doing refractive lens exchange. Probably if they have a lens which does not cause that kind of a shift in the posterior capsule and the volumetric changes, then that would kind of reduce the risk of retinal detachment. So that's probably something that the companies look at, changing the design of the lens in myopes so that you don't have that forward shift of the anterior capsule, of the posterior capsule when you're having the shrink wrap effect, so that you don't have the vitreous shift anteriorly and cause a PVD.
Well, I might add to Shree's comment, which I think is really right on target, that even if they have a posterior vitreous detachment, despite the myopred study, doesn't mean that the vitreous is not attached at the periphery, where it can still result in a tear. So you're not out in the clear, even if you see a full PVD.
Yes, the vitreous base is the strongest and the last to detach, so you can still have it.
Yeah, exactly.
That's, you know, we had a paper published in American Journal of Ophthalmology with 448 cases, which is a lot. It's the largest study published so far. And we could identify clearly two groups, an age. You know, those patients were myope with actually more than 26 and were less than 45. We had a factor of multiplied by 10 the risk of retinal detachment, less than 45. If these patients were more than 50, the risk was 10%. More. Okay, but if they were more than 55, the risk was that about the pre-med study, about 0.5%. So this definitely you have to get into account the age. But the other was the axial length and the power. In extreme marks, though, defined as those that had more than 29 millimeters, which are the really big eyes, the risk of having a retinal detachment in the following year, if the patient was less than 50, was almost 40%. So that means that we have a problem in the eye, and the problem is that we don't have the adequate tools to evaluate the vitreous. This is the problem. If we can evaluate the vitreous, I totally agree with Douglas, it's not enough to know that we have a PVD. PVD can be incomplete, can be complete, but how do we know that we have really the vitreous, not that the extreme periphery?
Jorge, have you published those data? Those are incredible data. Yeah, are those data available?
Yeah, it's published in American Journal of Ophthalmology.
Okay.
In the AGO, it was about 15 years ago.
Oh, wow.
Yeah, so it was the first paper, big paper on
okay.
this topic. I think that we have a question from the audience.
I don't think there is any rule of doing RLE in myopic patients. At any age, unless the lens gets sclerosed or some changes are there, because we have got the better options, we can do ICL, we can do IPCL, so we can cover practically whole of the range. And in these patients, again, the bag is too big, so we can't place a trifocal. Even EDOF may not be very good, because we don't know exactly the ELP. So getting a perfect trifocal or EDOF may not be very good. I think we shouldn't try in myopic at least. Of course, for hyperopia, it's a very, very good option. But for myopic at any age, I don't think CLE is the option.
No, the problem, Dr. Vinod, is that proponents of refractive clear lens extraction or refractive lens exchange, they convince patients that this is a permanent correction. So you need only one procedure and it lasts you for life. True. And I basically counsel my patients, either I do Presbyon or I do the ICLs. And when they go for a second opinion, some of the other doctors says that, why do you want to undergo LASIK? Why do you want to undergo ICL? You have a procedure which will give you a permanent cure. You don't have to have one single shot and then it is done. And this for the patients is very convincing, and then they go in and then after that they have problems, glare, halos, retinal detachment and all these other issues that can be there. Of course, though the percentage is low, the cumulative percentage of all the complications put in together, if you look at the risk-benefit ratio, I don't think it's in favor of the patient, especially for high myopes. So this is something which I'm very cautious about. And you have other procedures which are available, and they would last for quite some time. If you do an ICL or a presbyopic ICL or ICL monovision in ICL works very well because you have some amount of magnification which happens with the ICL. And this actually helps for reading also. So you don't have to have like 2 diopters, even 1.25 diopters. It gives them good reading. And these patients are very happy. And LASIK is much more accurate and precise than refractive lens exchange, especially for the reason that you said you're not sure about the ELP. That's the big elephant in the room that has not been addressed. There's no solution, perfect solution for that. So these are all things that we need to look at.
Right. I think that there is consensus in the panel about not to perform a refractive lens exchange with a good quality of vitreous. Second, about age. Which is your age limit in general?
I would not touch it before 45. It's a myope.
Yeah,
and I showed it in my presentation. There are two things, there could be some options where you cannot do a phakic lens, where you cannot do a LASIK. But then also, I would make the patient wait, tell him an option of contact lenses, let him go through the whole gamut of the thing before even thinking of saying yes, number one. Number two, in case the patient has a DLS set in, now what is my criteria for DLS is when I have a patient who on the Snellens is doing 20/20, but every time he comes back with a bad vision, and I've ruled out a surface disorder, and the Tracy is telling me there's a DLS. That's the time I actually step in. So for that, I need to have the patient above 50. I do not consider doing a phakic lens beyond 50 because I actually feel in a couple of years' time, sooner or later, because the lens is going to wall. The crystalline lens will have a little bit of change in the wall. There will be some sclerotic changes. The DLS is going to go up. The optical quality will go down. So my conscience on ethics does not let me to do 2 surgeries. So if the patient is beyond 50, 52, 53, and all parameters are okay, PVD is there, everything is settled, I may consider doing the surgery. But especially if the DLS is there. But if the lens is absolutely crystal clear, I would refrain from operating this patient.
Okay,
My
follow
second-
with your question.
Yeah. It's my personal opinion. I think the presbyopia starts, it's a progressive thing. It doesn't start at 40. Rather, it starts from the birth. At the birth, we have the maximum accommodation compared to a 10-year-old child. So it's a gradual process. By the time 40, it's become, we can't able to read or those things. But it's a continuous process started from the birth itself. What's your opinion, sir, on it? Dr. Professor Oli?
Well, you know, and I thought, you know, there are pros and cons always. You know, there is no black and white, and you have to think always in the benefit of the patient. The variables are age, the variables are risk factor associated to age, the variable is what is the patient demanding, and finally, what can you offer? What can you offer? And the problem is that in HIMAP you have a problem with conservative many times. Anti-focus might not be indicated, other options are fine, but I have very happy patients with trifocus. So this is the art of being a surgeon, but the first thing is not to lead to complications and to induce problems that you know by the evidence that can happen, okay? And now let's move to hyperopia. And you rightly pointed out, Kamal, the problem that we have with the powers, you know, because we have, when you are over 30, very few companies are providing services, only Indian companies, by the way, and beyond 35, virtually only Indian companies are covering. And then you have the option of order a special lens. The highest have been in my hands 44, Indian company, and very good. But piggyback, you mentioned that.
Yes.
So piggyback has advantages and disadvantages. The main advantage, the induction of high growth aberrations is far less with a piggyback. Because with high power lenses, you have a lot of spherical aberration. And so far, the companies are not that keen to modify the spherical aberration in the spherical. These lenses are spherical and induce positive spherical aberration. This is the point. And as you know, piggyback have the problems of interlenticular opacity. So how do you balance 2 situations? Come on.
So I think the trick lies in, number 1, going in for a 3-piece piggyback, number 1. Number 2, have a different material, if possible. Because I have had 2 patients where the patient had a hydrophilic lens implanted, operated somewhere in a small town, was a hypermetrope, had a residual of plus 14 refraction. I put in a 3-piece hydrophobic, and my biggest concern was this. That's how I started actually getting faith into using before the Sulcoflex lens and the Sulco ad lens and the ad lens by other companies. 3-piece lenses were working fantastic. Because of the different designs. So you need 2 different materials for not having an interlenticular opacification and possibly different designs also. So that does add up to your comfort zone of not having interlenticular opacification. I've done around 23, 24 cases. Luckily, no interlenticular opacification. In fact, one patient I do remember had the lens which was in a broken capsule, and the lens would just come up. The rhexis was gone. It was a 4-piece haptic lens. It would come up every little month. The lady was operated in Patna. All I did was I put a 0 diopter customized lens on top of the lens, a 3-piece lens, and the lens stayed in there in the back. The rhexis was gone, so the lens would float up.
So let me think, see if I understand. So implant one lens in the back, the other in the sulcus, always, number 1. Different type of IOL material, number 2. And different design, yeah. The problem is that when piggyback a high hyperop that needs 40, let's say, you have a small eye. Yes. And the sulcus flesh is not made for small eyes. This is one of the problems I face. I agree with you with the back and sulcus completely. The rest, which lens do you select for the sulcus? Because usually these lenses are made for standard eyes and not as much as for high hyperopic eyes, especially with non-ophthalmic eyes. This is why I still have cases in which I prefer a 40 lens customized by these fantastic Indian companies that very high quality indeed, and they play the service, you know. So what do you think?
Again, for moderate hyperopia, with a narrow angle, occludable angle, yes, refractive lens exchange is a good idea. You can have a fairly good calculation with some of the newer formulae. But when you're looking at high hyperopia, then even a very small shift in ELP with a customized lens can throw off your target, and then the patient can have residual refractive error, which defeats the purpose. So my preference for high hyperopia is that I do a two-stage procedure. So I put in a lens, and then I wait for about a week or two, and then do a refraction, and then put in a phakic IOL. And with this, it works very well because you know the refraction, you can correct the refraction up to like 10 diopters plus 10 with a phakic IOL, and you don't have to use a very high custom lens, which causes a lot of, again, unwanted abrasions, and also the ELP shifts can give rise to a high, so custom lens, again, has to be viewed with a little bit of caution.
Okay, and just to finish now this symposium, Brian, how do you handle your hyperops, emitrops, which is the third group that is really the cumbersome?
First of all, in my country, there are very few hyperopia.
That's the problem.
If the patient over 50, they can accept the refractive lens exchange, yes.
Yeah.
Yes, but
Correct.
below 45, there are few patients, they accept the lens exchange. They do the cornea refractive surgery or ICL, phakic IOL. And about the lens type of the hyperopic refractive lens exchange, I always suggest my patient to use the EDOF. And the both eye do micro monovision. Because they are hyperopic before the surgery, their presopic is very heavy. So EDOF plus micromonovision is very enough for them.
Very good. Come on, do you want to add something?
I do the same. When I'm a little bit confused about the lens, I go in for the safest best. I go for an enhanced monofocal with a blended vision of 0.5 in the non-dominant eye. That's a very safe zone. That's a sweet spot. You're not playing high with the aberrations. You're not played around with other optical system of the eye. And the patient gets a very decent, and especially my patients who are tall, they are super happy because they have a longer arc length. Yes, shorter patients may complain, but during my chair time, I've already told the patient that you may require glasses for near, but tall patients are very happy with this combination of an enhanced monofocal and the other eye by 0.5 myopia, and they have longer arms, and they do very well.
Well, we have to close the symposium, and I think that we have to summarize. There is consensus about the risk-benefit for the patient, always thinking the patient, always thinking the potential complications, and this happens more in the myopic patients with elongated eyes more than 26 and age less than 50, and even age before 45 in low myopes should not be performed. Second, in hyperops, you have different choices. Micromonovision seems to be good because remember, and this is not yet told in this table, there is a magnification of the quality of retial image. We magnify the image in the myop, but winify the image in the hyperop. So this make a loss of contrastivity. These high hyperopic patients are not for multifocal lenses. They are for EDOF with micromonovision, I totally agree. And number three, the lens power in negatives is a problem. I had a patient that requires a -14, and I had to do a piggyback, and they do well. But piggyback in the hyperops is difficult, sometimes because you have non-standardized. There is small, and you have to consider always what to do, patient to patient. Finally, the induction of aberrations is not that bad. I have to tell you that most of my patients with high hyperopia and high plus lenses are expected independent for near, because positive spherical aberration is good for near. Yes. And that's the point. And if you use two lenses, the combination of two optics makes extended depth of field. So this is something that you don't need in high hyperops that much concern about getting to multifocals because you have a natural increase in high aberrations with the spherical lenses. I want to thank the panel for this excellent discussion and debate, and all of you for being here today in this session. That indeed I have learned a lot about how to handle my patients. So thank you very much, and the session is closed.
Thank you. Thank you.
we're leaving here because we have the person from the company, some information about a new book that has appeared about creative pigmentation that has been released just in this session. I am the author of this book with other authors as well. Thank you.
We'll have a group photograph. Dr. Vinod, join us for a photograph.
The traditional picture. Okay, finally, this one.